Hello, my name is Colin Delong and I'm a general surgery resident at Penn State. Today's lecture is on mesenteric ischemia. I wanted to start the lecture out with the two most important buzz phrases that you'll hear as medical students linked to the diagnoses, and that is pain out of proportion to exam and intestinal angina. Pain out of proportion to the exam refers to a patient that is complaining of very profound and severe abdominal pain, yet on abdominal examination does not have a typical exam that you would expect for someone with this much pain, meaning they don't have necessarily signs of peritonitis. Intestinal angina refers to severe abdominal pain after eating. This is also referred to as food fearing. So, what is mesenteric ischemia? Essentially, it's interruption of the normal hemodynamic state of the abdominal viscera. This can be either acute or chronic. Acute mesenteric ischemia is a surgical emergency, while chronic mesenteric ischemia is something you may see in the clinic setting and can sometimes need elective surgical repair. Any discussion of mesenteric ischemia requires anatomical understanding of the blood supply to the abdominal viscera. As a brief review, the abdominal viscera is supplied by three main arteries coming off of the abdominal aorta, starting superiorly at the celiac axis, next down to the superior mesenteric artery, and finally the inferior mesenteric artery. These three arteries correspond with the embryological structures of the foregut, midgut, and hindgut. The celiac axis supplies blood to the liver, stomach, abdominal esophagus, spleen, and the superior half of the duodenum, as well as the pancreas. The three main branches of the celiac axis are the left gastric, which give off an esophageal branch and a stomach branch, the splenic artery, which gives off the short gastrics, as well as the left gastroomental artery, and the common hepatic artery, which eventually splits to the proper hepatic artery, the gastroduodenal artery, and the right gastric. The next important arterial branch is the superior mesenteric artery, which normally arises around L1 and is usually approximately 1 centimeter distal to the celiac axis. Branches include the inferior pancreatico-duodenal artery, as well as the ileocolic, right colic, middle colic, and jejunal and ileal arteries. I wanted to take a minute now to cover a few diagnoses that can be easily confused with mesenteric ischemia given similarities in their names, but actually represent very different clinical entities. The important thing here is that there are two structures that lie between the angle of the aorta and the superior mesenteric artery. Those two structures are the left renal vein and the third part of the duodenum. As such, in cases where this angle is too acute, it can cause compression of either of those two structures. When the angle between the aorta and the SMA compresses the left renal vein, this can cause hematuria, abdominal pain, and testicular pain, given that the left gonadal vein drains from the left renal vein. And this is called nutcracker syndrome. Secondly, when the third part of the duodenum becomes obstructed between this angle, this can lead to a gastric outlet obstruction, which would present as abdominal pain, nausea, and vomiting, as well as feeding intolerance. And this is called SMA syndrome. I just wanted to point these out because these are commonly seen diagnoses on examinations and are related to the anatomy of the superior mesenteric artery, but not related to mesenteric ischemia. The third and most distal branch of the aorta supplying blood to the abdominal viscera is the inferior mesenteric artery. Branches of this include the left colic artery, the sigmoid branches, and the superior rectal artery. Another important point to consider when discussing mesenteric ischemia and abdominal vasculature is the interconnectedness between these three systems. For example, between the SMA and IMA blood flow, there is connections, including the marginal artery of Drummond, and the arc of Rieland, which are vascular arcades within the colonic mesentery. Of note, a watershed area refers to a point where the two of these meet, and is an area that is at risk for low blood supply. One such area is at the splenic flexure. Additionally, it should be noted that there is a connection between the celiac axis and the SMA, usually through the pancreatico-duodenal arteries. It is also important to understand the abdominal venous anatomy, keeping in mind that this system is called the portal venous system, as it drains blood from the abdominal viscera through the liver. Importantly here, the portal vein is created by the confluence of the splenic vein and the superior mesenteric vein. Now we'll turn the discussion to acute mesenteric ischemia. You can see the incidence is relatively low, less than 1% reported per patient year at tertiary referral centers. However, the mortality is very significant, ranging from 30 to 80% 30-day mortality. And the operative mortality, or the perioperative mortality, is also very high, as high as 69%. A startling fact when considering acute mesenteric ischemia is that the mortality rate has not improved in the last 2 decades. There are 4 main subtypes of acute mesenteric ischemia, which we will discuss now. The first type of mesenteric ischemia is from embolic inclusion. This most commonly involves the superior mesenteric artery, and risk factors for embolic occlusion include risk factors like atrial fibrillation. In these cases, the emboli often lodge approximately 3 to 10 centimeters distal to the origin of the SMA, which sometimes leads to sparing of the middle colic artery. The next subtype is acute thrombosis, which most commonly occurs in patients with a history of chronic mesenteric ischemia. Unlike the embolic type, this typically affects the origin of the SMA, and as such, the entire midgut is often involved. The third type of acute mesenteric ischemia is called non-occlusive, also known as NOMI, N-O-M-I, for non-occlusive mesenteric ischemia, and this is caused not by obstruction of blood flow, but rather by a low blood flow state, and as such, the entire bowel may be involved. The fourth subtype of acute mesenteric ischemia is mesenteric venous thrombosis. This is where there is thrombosis of the veins draining the intestines, including the SMV, IMV, splenic vein, and portal vein, which leads to increased venous pressures and decreased arterial flow to the bowel. Next, I'm going to go into a little bit more detail about the 4 subtypes, starting with embolic. The classic presentation for embolic acute mesenteric ischemia is sudden onset of mid-abdominal pain, sometimes described as pain out of proportion. You can see that almost all of these patients have pain, but also can commonly have nausea, vomiting, diarrhea, and blood per rectum. When eliciting a history in these patients, it's important to look for risk factors that would cause any type of embolic event, including atrial fibrillation, a recent myocardial infarction, a mural thrombus, or mitral valve disease. You can also ask the patient if they've had a previous history of other embolic events, including myocardial infarction or limb ischemia. The next subtype, again, is thrombotic. Again, the presentation in this case is very similar to embolic, but they have a different underlying history. The history in these cases often involves a long history of chronic mesenteric ischemia, which would include postprandial abdominal pain and food fearing. And these patients often have evidence of other atherosclerotic diseases, including coronary artery disease and peripheral arterial disease. The third type of acute mesenteric ischemia is non-occlusive. This is a very different presentation from the sudden onset of abdominal pain seen in thrombotic or embolic subtypes. In these cases, the patients often have waxing or waning pain, which is linked to their hemodynamic stability. This is most often seen in patients in the ICU, often who have some type of shock leading to low blood flow states, and also for patients who are on pressors, which also predisposes them to this condition. It's very important to consider this diagnosis at all times and to have a high index of suspicion because it can often be missed in patients who are intubated or sedated and unable to verbally make complaints of pain. The final subtype of acute mesenteric ischemia is mesenteric venous thrombosis. This also presents differently than the classic sudden abdominal pain and actually can be associated with various nonspecific abdominal complaints, including nausea, vomiting, diarrhea, and crampy abdominal pain. The history in these patients often leads to identification of a hypercoagulable state, whether that be from cancer, oral contraceptives, or a genetic predisposition to clotting. Now that we have discussed the clinical presentation and history of the 4 subtypes of acute mesenteric ischemia, we'll move on to establishing the diagnosis. First, it's important to note that there's no pathognomonic lab finding associated with the diagnosis. However, you may see signs of hemoconcentration, a left shift leukocytosis, and metabolic acidosis. The best imaging test to order in patients with this suspected diagnosis is a CTA, which includes 3-dimensional abdominal imaging as well as imaging of the vasculature of the abdominal viscera with contrast. Most commonly on these imaging studies, you will see only non-specific findings of bowel compromise. However, there are some specific signs you should be aware of, which include a distal or proximal cutoff for patients with embolic or thrombotic disease. As well as for patients with non-occlusive disease, you can see segments of vasospasm. And for patients with venous thrombosis, the arterial blood flow will be intact. However, there will be no delayed images of the veins on the CTA. This is an example of a CTA showing a sagittal view where you can see the takeoff of the celiac axis as well as the SMA. If you look within the SMA, however, you see that there's an abrupt cutoff in the mid-SMA, which will be consistent with an embolic source. Next, I will show a few images of nonspecific signs that may be associated with mesenteric ischemia. In this axial CT scan, you can see a significant bowel wall edema, which would suggest poor blood flow to the bowel, as well as a significant amount of free fluid within the abdomen. This axial CT scan demonstrates pneumatosis intestinalis, which refers to air in the wall of the bowel and is most frequently seen in cases of vascular compromise. The CT scan demonstrates portal venous gas, which is air within the portal veins, shown here within the liver. This finding, again, is most commonly seen when there's severe ischemia of the bowel. Finally, this CT scan demonstrates the finding of pneumoperitoneum or free air, which suggests that there has been a perforation of the bowel. There's not always a perforation of the bowel in mesenteric ischemia. However, when there is poor or non-existent blood supply to the bowel, eventually the bowel wall thins and then perforates. Next, we will discuss treatment for acute mesenteric ischemia. First, the general goals include fluid resuscitation of the patient, correction of metabolic acidosis, initiation of broad-spectrum antibiotics, and anticoagulation when indicated. The surgical goals then are to restore pulsatile blood flow to the superior mesenteric artery, to resect non-viable intestine, and to eventually restore intestinal continuity. It is important to attempt to restore blood flow to the bowel prior to resection because some areas that may look to be severely compromised may significantly improve when blood flow is returned. And in these patients who may be losing other segments of small bowel, it is important to save as much small bowel as possible to avoid short bowel syndromes. There are numerous options for assessing blood flow uh, during the operation, including the use of a Doppler to listen for pulsatile signals within the bowel, as well as using fluorescein and a Woods lamp to visualize if the contrast is flowing through the bowel. Finally, there's a new technology called SPY technology, which can also be used to assess blood flow. The specific therapies for each type of acute mesenteric ischemia are very intuitive if you consider the cause of the obstruction of blood flow in each case. For patients with an embolic source, surgical management involves removal of the embolus to restore blood flow. To do this, the superior mesenteric artery is identified surgically, and then proximal and distal control is gained. Next, a longitudinal arteriotomy, or an incision into the artery, is made, and then an embolectomy balloon is eventually passed into the distal artery to try and remove the embolus. And once blood flow is restored, the arteriotomy is closed with a vein patch. For patients with thrombotic occlusion of their SMA, the typical management includes a bypass procedure. This can be done in an antegrade fashion, meaning from the supraceliac abdominal aorta, or a retrograde fashion, meaning from the distal abdominal aorta or the iliac artery. The preferred graft is the greater saphenous vein. However, synthetic grafts can be used. The advantage of using the greater saphenous vein is reduced risk of infection, particularly in patients who may have had contamination of the abdominal cavity. The management of non-occlusive mesenteric ischemia is almost always non-operative and supportive, involving fluid resuscitation and improvement of cardiac output and elimination of pressors. There can be selective catheterization of the SMA with infusion of vasodilators, such as papaverine, but this is relatively rare. And these patients should only progress to the OR if they have signs of bowel perforation. Finally, the management of patients with venous thrombosis is often resuscitation and anticoagulation. These patients can undergo catheter-directed thrombolytic therapy, but again, this is relatively rare. And surgery for these patients is also not indicated. Venous thrombectomy is not effective in these patients, and similar to patients with non-occlusive mesenteric ischemia, progression to the OR should only be prompted by concerns for severe bowel compromise and perforation. I'd like to end this lecture with a brief discussion of chronic mesenteric ischemia. This refers to the chronic inadequate arterial perfusion of the abdominal viscera, and given the collateral flow mentioned at the beginning of this lecture, needs to involve at least 2 of the 3 main arteries for the patient to be symptomatic. Causes of chronic mesenteric ischemia is most likely to be atherosclerosis involving the origins of the SMA and the celiac artery. However, rare causes do exist, including SMA arterial dissection and arteritis. I did want to mention briefly one diagnosis which can be confused with chronic mesenteric ischemia based on a similar presentation and can also be commonly tested. This is median arcuate ligament syndrome, which is when the median arcuate ligament, which is basically fibers coming off of the diaphragm, impinge upon the celiac axis, leading to decreased blood supply and food-fearing weight loss and abdominal pain. The therapy for this, however, is a release of that ligament, which can be done laparoscopically. The presentation of chronic mesenteric ischemia involves intestinal angina or postprandial pain and food fearing, which can often lead to significant chronic weight loss. Because chronic mesenteric ischemia is considered a precursor to intestinal infarction, just like unstable angina is considered a precursor to myocardial infarction, the treatment goal is revascularization. These patients often are asymptomatic initially because of the significant amount of collaterals. And as I already mentioned, to have the diagnosis, they need to have significant occlusion of at least 2 of the 3 arteries, one of which is always the SMA. The best screening diagnostic modality for chronic mesenteric ischemia is a visceral duplex, where numbers such as a peak systolic velocity and end diastolic velocity can be compared in ratios to assess the level of blood flow at different points within the abdominal viscera. Additionally, a CTA can also be obtained. The 3 treatment options for chronic mesenteric ischemia include endovascular interventions, endarterectomy, and open bypass grafting. Endovascular interventions are best suited for focal arterial lesions. Stent angioplasty is preferred over balloon angioplasty because of the recoil potential of calcified plaque following balloon angioplasty. Access can be obtained via the brachial or femoral arteries. There is, of course, a risk of embolic events with this type of therapy, which must be understood by the patient and provider prior to the intervention. While endovascular interventions do offer a lower morbidity and mortality than open surgery, this comes at the price of durability, in that there's a 1-year failure rate of the intervention of around 30%. Endarterectomy is a viable treatment option when the occlusive disease involves the entire para-aortic visceral segment. This cannot be used when the plaque is greater than 2 centimeters from the origin, in which a bypass is the preferable treatment option. In this therapy, an incision is made within the aorta, and the plaque is then completely excised, and the incision is then repaired. Finally, arterial bypass grafting can be performed for long segment stenosis or occlusions that is not amenable to stent angioplasty or endarterectomy. This is performed in a similar manner to that described for acute mesenteric ischemia. Finally, I wanted to mention a few more clinical pearls that can be confused or are associated with mesenteric ischemia. First, the idea of benign pneumatosis. While many cases of pneumatosis intestinalis seen on CT scan come from an underlying pathology, there can be benign causes of pneumatosis, and these should be considered prior to taking a patient to the operating room, particularly if the patient is hemodynamically stable and not displaying signs of abdominal pain. Finally, mesenteric ischemia should not be confused with ischemic colitis. Mesenteric ischemia most often involves compromised blood flow to the small bowel and is a macrovascular disease, meaning that a bypass or embolectomy can be used for therapy. On the other hand, ischemic colitis, as the name refers to, is a low blood flow state to the colon. However, this is almost always a microvascular problem, such that revascularization is not a viable therapy. Thank you.